Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on obstructive lung disorders. Okay, let's do some questions. Question 1 is a 65-year-old man with a BMI of 30 who presents with his partner to the respiratory clinic. He reports a 6-month history of fatigue and daytime somnolence. On speaking with the partner, it appears that she also has poor sleep due to being awakened by snoring sounds. Given the likely diagnosis, which of the following is the optimal confirmatory test? So the options are A. Epworth Sleepiness Scale, B. Color Measurement, C. Polysomnography, D. Overnight Pulse Oximetry, and E. Pulmonary Function Test. So going back to the question, hopefully this is all ringing alarm bells for all of you that this is a classic case of obstructive sleep apnea. You've got a middle-aged man who is significantly overweight, is coming to the respiratory clinic and is complaining of daytime tiredness, and also very helpfully his partner is also there who tells you that she keeps getting up because of him snoring throughout the night. So really getting the diagnosis of OSA is the easy part in here. Now the question is asking you about the optimal confirmatory test, i.e. the gold standard. This is not asking you about what's the first appropriate investigation to start, and because it's asking you about the confirmatory test, the gold standard confirmatory test, as you know, for obstructive sleep apnea is option C, which is polysomnography, which is basically sleep studies. So they would be admitted overnight to a sleep lab in a controlled environment. They would have all sorts of various different measurements taken, from pulse oximeter to saturation level to heart rate and brain waves. However, as mentioned before, please be careful if they ask you what is the first investigation that you would be due to assess the underlying cause. Obviously, that would be a bedside, quite an easy and accessible test such as Epworth Sleepiness Scale.
So let's try a couple of questions. A 23-year-old patient presents to his GP with a 6-month history of intermittent dry cough with associated breathlessness and wheeze. He has noted these symptoms are worse when he is at work in the local factory. The GP suspects a diagnosis of occupational asthma. What is the most appropriate first-line investigation to help with the diagnosis? So our options are chest x-ray, peak flow diary, skin prick testing, bronchoscopy, or spirometry. Now, you'll remember when we discussed this that the peak flow diary is really important when first making a diagnosis of asthma, particularly when an occupational exposure is thought to be the trigger. So B is the correct answer. Question 2. A 28-year-old female with difficult to treat asthma has been sent to the tertiary asthma clinic for consideration of initiation of biologic. The consultant chest physician decides to start the patient on omalizumab. What is the mechanism of action of omalizumab? So our options are anti-IL-5 receptor, anti-IL-5, anti-IgE, anti-TNF, or anti-IL-6. So you'll remember, hopefully, that omalizumab is an anti-IgE drug. The other 3 biologics which are licensed for asthma are either blockers of the IL-5 receptor or IL-5 itself. Anti-TNF and anti-IL-6 drugs are not used in the treatment of asthma.
Question 1. A 30-year-old lady presents by ambulance to the emergency department. She has a known history of asthma. She is dyspneic with an audible wheeze and her respiratory rate is 28 breaths per minute. Her initial oxygen saturation is 88% on room air. Her peak flow is 20% of predicted. Her examination reveals an irregular heart rate, which is new. An arterial blood gas reveals a CO2 within normal range. What is her class of asthma severity as per the above information? A. Mild, B. Moderate, C. Severe acute, D. Life-threatening, and E. Near fatal. And if you go back to the vignette again, you have somebody who's a known patient with asthma, who's coming in with audible wheeze. Her respiratory rate is 28 and SATs of 88. She does have arrhythmia that is new for her, and her ABG shows that CO2 is normal. Hopefully, if you've been listening so far, you will realize that this is bad news. And if you have somebody in that scenario, according to the NICE or British Thoracic Society guidelines, whichever you go with, this patient is automatically classed as life-threatening asthma. Therefore, the correct option is option D.
So now time for a question. A 65-year-old gentleman with known diagnosis of COPD is getting assessed for possibility of long-term oxygen therapy after recovering from a recent episode of exacerbation. Which of the following is not an indication for long-term oxygen therapy, or LTOT? So these are our options. We've got A PaO2 of 7.4 kilopascals with bilateral pedal edema, B, PaO2 of 7.9 kilopascals with signs of RV strain on ECG, C, PaO2 of 7.1 on this encounter, D, PaO2 of 7.8 kilopascals with raised hemoglobin count on FBC, and E, PaO2 of 7.6 kilopascals with cor pulmonale. So the correct answer here is C, because we only have one reading from which to make a decision, and you'll remember that we need to have 2 readings on the ABG at least 3 weeks apart before considering someone for LTOT.
Let's do some questions now. A 70-year-old lady is brought by ambulance to the emergency department with a 1-week history of cough accompanied by production of green sputum. She has a background of COPD. Which of the following statement is incorrect? A. She should receive an annual influenza vaccine and pneumococcal vaccination every 5 years. B. Smoking cessation and pulmonary rehabilitation are key to management. C. Her chest X-ray is likely to show hyperinflation. D. She should be immediately started on therapy with inhaled salbutamol and ipratropium and steroids. E. She should be considered for CPAP if her ABG is not improving after 1 hour despite optimal medical therapy. And if you recall from our previous video on the management of COPD in long term, you would remember that the options A is correct. And these patients will need to have annual influenza and 5-year pneumococcal vaccines. As discussed earlier, about 80% of cases with COPD is caused because of smoking. And any time the patient can stop smoking is going to increase their chances of survival. Therefore, smoking and engagement with pulmonary rehabilitation is strongly recommended. C is a chest X-ray, which very frequently shows hyperinflation or hyperexpansion, which is a radiological sign in patients with COPD. And D is describing the immediate management that I'm pretty sure all of you would be familiar with, which is back-to-back nebulizers and steroids. And E, it is correct, however, if it was mentioned for BiPAP instead of CPAP. If you want a recap of the differences between BiPAP and CPAP, please click here. However, CPAP is not going to be the choice of treatment for patients with COPD. Remember, patients with COPD have problem with excreting carbon dioxide, therefore providing them with more and more diaphragmatic splinting, and more oxygen is not going to help with that. They would need oxygenation, however, they would also need help with excreting that carbon dioxide, which CPAP is not going to offer, and the correct mode of ventilation will be bimodal or BiPAP. Therefore, option E is incorrect. So let's do some questions. A 60-year-old lady with a background of rheumatoid arthritis presents to the respiratory clinic with a 2 months history of progressive breathlessness associated with productive cough of clear sputum. Her spirometry shows an obstructive defect, and she has undergone a HRCT that was requested by chest physician, which demonstrates bronchial wall thickening of the segmental and subsegmental bronchi with mosaic perfusion. So hopefully, if you guys were listening, you will realize that the HRCT finding is very specific and highly suggestive of bronchiolitis obliterans. Given the likely diagnosis, which of the following statement is correct? A. Treatment with steroid is indicated. B. Rheumatoid arthritis is not associated with this condition. C. Definitive diagnosis can be obtained via lung biopsy. D. The condition usually has excellent prognosis if rheumatoid arthritis is well controlled. E. Her FEV1 will be normal on spirometry. If you guys were listening during the video today, you will realize that the correct option is going to be option C, which is definitive diagnosis can be obtained via lung biopsy, because it will allow you to give tissue to the lab and they will be able to have a look at it and find out what's actually going on. But just for your own learning, in terms of going through the other options, treatment with steroid is not indicated usually in the cases of bronchiolitis obliterans. As you know, unfortunately, it's one of those conditions that has very poor prognosis and there is no single treatment that can actually improve it. Rheumatoid arthritis is associated with this condition and in fact is the commonest cause in terms of the connective tissue diseases that could lead to this condition. The condition doesn't have an excellent prognosis even if you have the underlying conditions such as rheumatoid arthritis very well controlled. And FEV1 will normally show an obstructive pattern as opposed to a normal pattern on spirometry.
So now let's try a question. A 20-year-old female patient with a diagnosis of cystic fibrosis comes to hospital with a 5-day history of shortness of breath and productive cough with green sputum associated with fevers and chills. What organism does not commonly colonize the respiratory tract in patients with cystic fibrosis? So our options are Haemophilus influenzae, Staphylococcus aureus, Pseudomonas, Burkholderia, and Streptococcus pneumonia. So in this particular case, the correct answer is Streptococcus pneumonia. All of the other options given are organisms that can be seen in people with cystic fibrosis.
Okay, so let's do some questions. Question 1. A 50-year-old lady presents with a 3-month history of worsening breathlessness on ambulation associated with a productive cough of clear sputum. She has a history of recurrent childhood bacterial infections and rheumatoid arthritis since the age of 25. On examination, the IMT2 doctor notes evidence of articular changes consistent with long-standing rheumatoid arthritis and an early inspiratory coarse crackles on auscultation of the chest. Given the likely diagnosis, which of the following is correct? And the options are A. Small cell lung carcinoma is the most likely. B. Rheumatoid arthritis is not a risk factor for her condition. C. Her chest x-ray will definitely be abnormal. D. Signet rings may be present on HRCT. And E. Double lung transplantation is indicated. So if we go through these one by one, hopefully the history has been hinting and suggestive enough for you to be thinking about bronchiectasis, because this is a middle-aged lady who's presenting with breathlessness and productive cough of clear sputum. And she has got risk factors of rheumatoid arthritis and recurrent childhood bacterial infection to have the condition. And more importantly, the IMT2 doctor has picked up signs and symptoms consistent with bronchiectasis. So really the question is supposed to be testing your knowledge on bronchiectasis. So therefore, automatically option A is going to be incorrect because small cell lung cancer is not the most likely cause. There is no other risk factor such as smoking, for instance, that has been mentioned in the vignette. If you want a refresher of small cell lung cancer, please click here, in which we have discussed in depth the manifestations and presentation and management of small cell lung cancer. Option B is going to be incorrect because we know that autoimmune conditions such as rheumatoid arthritis is going to be a risk factor for bronchiectasis. Option C is her chest x-ray will definitely be abnormal. Hopefully by now you have realized that usually if there is the option of definitely in an MRCP question, it's most likely going to be incorrect because, as most of you will know, medicine is not not black and white really, and is most of the time in the gray zone. So having definitely is going to be incorrect most of the time. And in her case, this is also incorrect because she could have abnormal chest X-ray. However, we know that in bronchiectasis, especially in earlier stages, the chest X-ray is very frequently normal. Signet rings may be present on HRCT. That is the correct option. And that's in fact the classic signs or radiological finding on HRCTs in the case of bronchiectasis. And then finally, double lung transplantation is indicated, which is incorrect in here because the first thing that's going to be indicated is excluding an infection. And then second thing is going to be all the management options that we discussed earlier. And double lung transplantation is certainly not something that you would be considering as a first line therapy. Question 2. Which of the following is not a radiological feature consistent with a diagnosis of bronchiectasis on either chest X-ray or HRCT? A. Tramlines representing thickened bronchial walls. B. Signet rings generated by enlarged bronchus. C. Ring opacities. D. Finger and glove appearance from impact central bronchi. E. Honeycombing. And if you remember, we have just discussed that signet rings are the classic finding in HRCT. So option B is going to be correct. And options A, C, and D are the options that can be found on chest X-ray finding on the cases of bronchiectasis. And bear in mind, chest X-ray, as we discussed earlier, could be normal. So it will leave you with option E, which is honeycombing, which is frequently seen as a CT scan finding on the case of pulmonary fibrosis, not bronchiectasis. If you like a refresher on pulmonary fibrosis, please click here. Thanks for listening to this episode of Bite Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.